what I'll do is I'll take you through the basics first. That's very important. Then I'll share the important points with you, some of which will be an overlap with Dr. Atanupal, my previous speaker. And because this is supposed to be a case-based discussion, I'll take you through a series of real-life clinical photographs because photographs tell a better story. This is something that everyone has seen, a patient undergoing dialysis from an excess in the arm, because this is a disease where water is fire and potassium is poison. Now, till the 36th edition of Harrison's Principles of Internal Medicine, this had always been there, that long-term vascular access is the Achilles heel of hemodialysis. Now, a quick return to basics. Vascular access can be catheter-based or surgical. Catheter-based is temporary, short-term, are called vascats, and not permanent, but long-term, as Dr. Pal said, are perm cats. They are similar to vascats in principle, but they are cuffed, tunneled, and more sophisticated E-Teflon material. It's very important to understand, as we see the next picture, the basic anatomy of the upper central veins, especially for the residents and the DM candidates, that dialysis catheters are not the same as the central venous lines we see or use in ITU. They are far bigger catheters, and if they are present for a longer time, and they are present for a longer time, they invariably cause a degree of endophlebitis and has a greater propensity of causing a stenosis in the vein. Number one. Number two, the subclavian vein, which is the pointer? The subclavian vein is notorious for stenosis. This is a vein which should never be used for a dialysis catheter. Now, a quick recapitulation of the basic anatomy of the forearm veins. The cephalic vein runs a subcutaneous course throughout the upper limb, usually seems to disappear at the bottom of the deltoid, but it's still there. It drains directly into the subclavian vein here. Unfortunately, the bigger vein at the elbow on the medial side, the basilic vein, that penetrates through the deep fascia in the lower fourth of the arm and goes inside and joins the vena comitans of the brachial artery to form the axillary vein. Now, this is the most important message for everyone dealing with these patients, that the ideal vascular access for hemodialysis is a native AV fistula in the distal non-dominant forearm. Unfortunately, this is very often not possible, or they fail. Now, there is no uniform definition of difficult vascular access. It is generally agreed that either lack of visible or palpable forearm or arm veins plus a problem with placing a central venous catheter would be a difficult access, or one or more failed native AV fistulas. Now, diabetics are more likely to have difficult access because of higher incidence of atherosclerotic disease and poor arteries. There is poor flow, there may be proximal plaques, and there is invariably, very commonly, an anastomotic difficulty in heavily calcified arteries. You need special techniques, sometimes focal endarterectomy at the site of anastomosis. There is delayed maturation, and proximal venous stenosis is more common in diabetics from the central venous catheters. And almost every form of access complications, infections, steals, aneurysms, as pointed out by Professor Seal, they are more common in diabetics. Now, what are the options? What options do we have in a failing or a failed dialysis access? We do have options of endovascular salvage, plasties, stents, and thrombolysis. I'll elaborate on this a little bit more. Plasties are very effective when a fistula is failing, that due to a proximal stenosis. Classically, the patients or the technicians will report that time to cessation of hemostasis, the blood stopping after cessation of dialysis is increasing. They have to use greater pressure on the bandage, so there is likely to be a proximal stenosis. We use high pressure balloons, and we usually go up to 20 atmospheres. Beyond that, there is a risk of fistula rupture, which, invariably it will happen in 1 or 2 patients. Stents are rarely used. There are very rigid indications of stents in central venous stenosis. But we do use covered stents in a running access across an area of pseudoaneurysm. We have done that in few cases, about 6 or 7 cases. Unfortunately, they are expensive but effective. Thrombolysis is useful only if you have seen the patient after a clotted AV fistula very soon, within 24 hours. Otherwise, they generally do not succeed. Surgical salvage, again by thrombectomy or a diamond patch plasty, because the usual culprit is the venous outlet. And more commonly, we have to do redo procedures in the form of proximal transpositions, prosthetic grafts, and well, if these options are not possible, then only other possibilities, long-term central venous catheters. Very recently, last 2-3 years, we have got a special long IVC femoral palm cath. It came with a lot of hopes, but we are losing our hopes because the results are not very good. Now, why do accesses fail? I'll just take 2 minutes on this. Age, sex, obesity, and diabetes are internationally known factors. But what are the other factors? This was a very ambitious study. We planned for a 10-year prospective study, incidence, prevalence, and etiologies of access failure in hemodialysis patients. Unfortunately, after 2017, we could not carry on this study, but 788 patients were studied, and we found certain important things. Delay in initial referral to a nephrologist, delay in referral to access surgeons, multiple pre-dialysis hospital admissions, multiple forearm drips, and use of alternative medicine. Patients, when told that they may require a dialysis by a nephrologist or a diabetologist, they seek help from alternative medical practitioners who basically tighten their diet and say that we can avoid dialysis. And in the meantime, they get repeated hospitalizations. With each hospitalization, they get an IV saline drip. So to summarize, dialysis access can be primary or secondary native AV fistulas. There can be tertiary access with grafts and access complications. Now, there are several variety of prosthetic grafts. I'm not going to go into the details, but it's important to remember that in our population, contrary to the experience of the Western world, forearm loop configuration does not work well because in the South Asian population, there is a narrower caliber of the outflow veins. We published our first experience with our first 82 patients, and we showed the same result. This is a prosthetic graft, an EPTFE graft, a standard wall, and this is a loop graft. You can see the graft making a loop in the forearm. We found out that these do not work well. We published it, and now we do straight configurations from the brachial artery to the axillary vein. Rarely performed, but a very, very, very effective access. This is called a necklace graft, where you have a long segment central vein stenosis which you cannot cross with a wire through endovascular means, and you do not have an artery in the brachial arteries which can sustain a graft, which commonly happens in female diabetics. This is a graft like a necklace from one subclavian artery to the other subclavian vein. A very underutilized operation in our part of the country for unknown reasons. Basilic vein transposition is a tricky but a very effective procedure. The basilic vein is harvested in the arm. As you remember, it pierces the deep fascia. Note the nerve. The cutaneous nerve of the arm and the forearm has to be preserved because otherwise it leads to a lot of morbidity. This is at the end of the procedure. You can see the conduit dilated, not matured. It is dilated because it has been dilated by hydrostatic dilatation. This is a matured and ready for use basilic vein transposition. Even though it seems to be a long incision, surprisingly, patients tolerate this operation quite well. These two procedures have often salvaged patients with failed access, more than hundreds in our practice. Now, recent advances from a technical perspective, we have a better use of duplex imaging for mapping veins. We have CT venogram, by which we can find out non-invasively whether there is stenosis. Use of long segment transpositions or translocations, use of prosthetic grafts, and access salvage using endovascular options. I'll quickly take you through two pictures of a classical case for endovascular salvage. You can see a blocked fistula. The problem is here, the stenosis, and there is another stenosis at the junction of the subclavian and the jugular veins. Both were successfully plastered with high-pressure balloons. Very interesting. You see, this is a normal cephalic vein, but it was unsuitable because of a caliber problem. This was a graft, and the graft has blocked. You can see a long segment obstruction. This requires surgical thrombectomy and a patchplasty at the venous exit level, and again, this was salvaged. Now, I'll spend the last 3 minutes on access complications because as specialist physicians, you need to have some idea, snapshots of what you can see in your patients on the wards or on your outpatients. A classical primary fistula aneurysm. If the skin is shiny, if it is tense, and if there is any degree of tenderness, please, as soon as possible, refer this patient to the access surgeon. If this ruptures, the patient may not be able to reach the hospital. This is a different kind of aneurysm caused by needling. The most dangerous form of aneurysm, again more common in diabetics, is a mycotic aneurysm. Now, I'll draw your attention not to the aneurysm, but here you see the blister. And if you look carefully, you see a small degree of steel in the index finger. Presence of a blister around an aneurysm in an AV fistula or a presence of any degree of steel is extremely dangerous sign. Again, if this ruptures, the patient won't reach the hospital. This is called a serpentine aneurysm. Well, we named it. We had a series of 9 patients. We proved in each patient with biopsies and CT venograms that this is not caused by central vein stenosis, and they do not rupture very easily, and you can salvage them through a different surgical procedure. We presented this to the International Congress of Hemodialysis in 2014, got an abstract publication. We are waiting for more patients. If we reach around 20, hopefully this would be a publication. Very unusual, but this does happen. When you are exhausted of needling sites, technicians tend to needle higher up. The fistula is here. This is a traumatic AV fistula from the brachial artery. And this is again something very dangerous. This is the proximal, same patient. This is the shoulder. This is the proximal control of the subclavian artery taken. And this is the post-operative picture. Sorry, we could not remove the entire face. Ideally, the face should not have been seen, but at least it was salvaged. The point is, what next? If you can't transplant this patient, they need another access. In the Western world, this would lead to $1 million lawsuit. We have a program after this. This is classical Steele syndrome from a proximal high-flow AV fistula. There are methods to salvage this. There are drill procedures, Drell procedures, but at the end of the day, she will end up losing at least 1 and 1.5 fingers. From a femoral catheter, you would come across these. What do we need today? I'm finishing. We need access surveillance, greater availability of endovascular services, and greater availability of surgeons for higher forms of access. My special thanks to Dr. Jayanta Das. He has been working with me for the last 17 years. Dr. Shubhroto Banerjee, and our radiologist and our nephrologist. I was asked to end with a 2-liner course summary. My course summary to all of you is, whenever you see a patient with a raised creatinine, even in an acute setting, please ask your juniors to save the cephalic vein in the non-dominant forearm. Don't drip it. And every dialysis unit or several units should be coming together and initiate an access surveillance program, identify and intervene before an access fails. Thank you.